l'Institut d'Investigació Sanitària Pere Virgili, donar aquest any o aquesta sessió està molt focalitzada en tota la pandèmia Covid, amb diferents aspectes relacionats amb la pandèmia Covid que, com molt bé sabeu, ens ha portat una mica de crani durant l'any passat i el que ens portarà durant aquest any almenys segur. I agrair, evidentment, als ponents, que avui tenim la sort de tenir una sessió plenària amb un magnífic ponent i també sessions d'investigadors del Pere Virgili i demà també, evidentment, amb aportacions molt interessants relacionades amb la temàtica de la sessió. Agrair també a la Comissió de Formació Continuada que organitza, que s'encarrega de la feina feixuga de cercar temes i cercar ponents que aixequin l'interès de la comunitat científica del nostre medi i, com ja he dit, els ponents i també els que participen, els participants que estan connectats per sentir les sessions d'aquesta tarda. Jo, amb aquest agraïment a tothom, vull donar per inaugurades aquestes 8enes sessions científiques i sense més pèrdua de temps dono pas a les persones que moderen la sessió plenària perquè donin pas al convidat d'aquesta tarda. Endavant i gràcies.
Well, good afternoon and welcome to everyone to this session. Today we have the pleasure to start this seminar with Dr. Roger Paredes, who is HIV physician at Hospital Germans Trias i Pujol, head of the Infectious Diseases Department at the IISPV AIDS Research Institute, adjunct associate professor at the Center for Global Health and Diseases in Cleveland at the Pathology Department. During the pandemics, Dr. Paredes coordinated the clinical care of COVID-19 patients at his department and has also been the Spanish coordinator of the clinical trials from the National Institute of Health about new treatments for COVID-19 in hospitalized patients. Nowadays, his team continues researching on multiple treatments both in hospitalized and outcome patients. He is member of the Program for the Harmonization of COVID-19 Drug Treatment, member of the 19 guidelines from SAIM, and also member of the WHO Global Clinical Platform for COVID-19 Clinic Advisory Group. The work that he is going to present today is entitled Advances in COVID-19 Drug Therapy. Dr. Roger, please, it's your turn.
So thank you very much for the invitation. I will try to share my slides. So I hope you're seeing the slides well. So thank you very much. First of all, thank you very much for the invitation. It's an honor for me to be able to give this lecture. I would really want to thank the organizers. This has been a very hard year, very intense. And on one hand, it has been very dramatic, but also scientifically, it has been very challenging and I would say that quite successful. This is quite evident in the vaccine world. We've been able to come up with very effective vaccines that are helping us a lot to fight the COVID pandemic, but also there have been a lot of advances in drug therapy, and I hope I will be able to summarize these advances and where the field is moving now. So first of all, let me start with my disclosures. I have received consulting fees and research funds from Merck, Gilead, ViiV, and Thera Technologies for HIV-related work, also from Gilead, Merck, and Lilly for COVID-19-related work, and I plan on discussing and label the investigational uses of commercial products, and I am, of course, disclosing this to the audience. Okay, so this has become a classical slide that we all use, and the concept behind the slide is that COVID-19 is actually a multi-stage disease. It is a disease that starts with a viral response phase. So we get a virus that gets inside our body and it starts replicating. And in many patients stop there. They just become cured spontaneously. The immune system is able to control COVID-19 replication and nothing else happens. Then, However, in 20% of our patients, more or less, they start to develop as lung inflammation and systemic inflammation, and then this initial viral response phase overlaps with an increasingly important host inflammatory response phase, which this is very important because every phase of every stage of this disease will probably require different treatments. So something that we have learned very quickly during this year is that we have been able to identify many drugs that do not work. And actually not only they do not work, but could potentially cause harm. We use these drugs because we didn't have the knowledge at the beginning, and essentially we were run over by the disease. But as soon as clinical science started to move on, particularly with the initiation of randomized clinical trials, we quickly understood that hydroxychloroquine, chloroquine, lopinavir, ritonavir, betaferon are drugs that are not working anymore, and I will not go into further details. So what is the current treatment of COVID-19? So here you have a summary slide of what is the hospital therapy of COVID-19 in Catalonia. There was a recent update, and I really like this slide because it shows that first we need oxygen and ventilatory support. That's for all patients. Then we need to use anticoagulants, heparin, usually at prophylactic doses, although there will be clinical trials that might potentially challenge this view. And then once this is for all patients, and in addition, then what we have is COVID-19 specific treatments, which essentially include antivirals. In fact, the only antiviral that we have available today that has shown effects in randomized clinical trials, which is remdesivir. And in addition, we then used anti-inflammatory drugs. Dexamethasone has been the first drug that been able to show benefits in terms of survival. And nevertheless, as I will show you later, there are a number of patients that fail to dexamethasone and require additional therapy. And more recently, Tocilizumab is an anti-IL-6, a specific monoclonal antibody, has been incorporated into the Catalan guidelines for specific patients. So what do we know? Why are we using remdesivir? So the evidence comes from this clinical trial in which we were able to also participate, and with many other sites in the world, showing that remdesivir was better than placebo. This is the ACT-1 trial, which has been, it's widely known and has been challenged as well. And one of the characteristics of this trial is that, well, it included patients in different stages of the disease. Overall, patients receiving remdesivir improved faster than those receiving placebo. However, in the subgroup, the highest effects were observed in patients requiring low flow oxygen, as you can see here in the part down on the left side. It is much more difficult to see an effect in patients requiring high flow oxygen or non-invasive mechanical ventilation, and there is absolutely no evidence of an effect in patients requiring mechanical ventilation. However, it has to be said two things. That first, that this study was not powered to observe differences in mortality. And the second one is that there is, so in the statistical interactions between these different subgroups are not able to tell us whether remdesivir is actually being effective or not in other groups. But nevertheless, we nowadays use remdesivir mostly in this group, in patients receiving low flow oxygen. You can see here the outcomes by ordinal score. So overall, remdesivir was associated with 30% faster recovery than placebo. And then if we zoom in into category 5, which is patients hospitalized patients receiving low flow oxygen, there was a significant reduction in mortality by day 14, which was not then confirmed by day 28. There is a lot of research being done. There will be at least 4 independent cohorts being presented in the European Infectious Disease Conference, showing survival benefit in these patients, receiving low flow oxygen. And also we are working in a meta-analysis using most of the main clinical trials And again, this will be confirmed in a much larger sample size. These Kaplan-Meier curves from the same clinical trials show you that actually there was a reduction, a trend towards reduction in mortality in subgroup 5, oxygen hospitalized patients receiving low flow oxygen. But as this is still an open question that has to be, that will come. There will be more data coming in. The ACT-1 trial was challenged by the results from the WHO Solidarity trial. The Solidarity trial, so the ACT-1 was a prospective randomized placebo-controlled trial. The Solidarity trial was actually an open label trial done in many places around the world. And in Solidarity, there was no effect could be seen of adding remdesivir, and that is the reason why many different groups are not using nowadays remdesivir in their patients. However, when you look into the lower risk strata, patients with no ventilation, again, trends were favorable to using remdesivir. And there are a number of issues with the Solidarity trial. One of the main issues is that Solidarity did not separate patients by low versus high flow oxygen requirements, which seems to be pretty critical. Another criticism against remdesivir comes from, which has been seen in different trials. And for example, in this trial from China, which was published immediately before the remdesivir ACT-1 trial, is that remdesivir does not does not accelerate the upper respiratory viral load, as you can see here, neither the upper respiratory or the lower respiratory tract viral load. This is actually not surprising, and this had been seen before in rhesus macaque models. Whereas in the left-hand side, if you look at the viral load in these macaques, so neither the bronchoalveolar lavage fluid or nose swab, you don't see any differences in viral load. However, if one takes cells and cultures those viruses, the patient macaques receiving remdesivir had significantly lower amounts of virus relative to macaques not receiving remdesivir. So in conclusion, we have to accept that remdesivir does not reduce upper respiratory SARS-CoV-2 load. However, upper respiratory viral load is actually a bad marker of drug clinical efficacy. This is just like what happened with flu. And actually, in consequence, for example, the CDC has issued guidelines saying that upper respiratory viral load should not be used for clinical trials to assess the efficacy of antiviral drugs in COVID-19. And actually, none of the NIH-funded clinical trials is using upper respiratory SARS-CoV-2 load as a proxy for clinical efficacy. The second second classical drug that we are using is dexamethasone. And yes, dexamethasone was found in the recovery study to reduce mortality, and differences were statistically significant, but it is important to read these results properly. Because when you see on the left-hand side, you see the effect in overall all participants, more than 6,000 participants. There was a reduction of 17% in mortality. The biggest effect, the largest effect in mortality reduction was actually in patients receiving invasive mechanical ventilation. So, which is patients with instituted respiratory distress. In this summary slide, you can see the effects of dexamethasone in our patients. So, for patients receiving invasive mechanical ventilation, there was a very large effect size. So we went from 41% mortality to 29%. So a reduction of 12 percentage points. However, when you look into the patients receiving oxygen only, and this does not separate low flow and high flow, although there was the difference in mortality was significant, the amount of effect was small, when going from 26% to 3%, so only 3 percentage points. which means that even if we use dexamethasone, there will be a significant amount of patients that will fail treatment, and therefore they require better treatments. So we have at least 2 drugs that do something, that have some moderate effects, but it is pretty evident that we require much more effective drugs to treat COVID-19 and in hospitalized patients, and that's why we continue to do research very, very intensively. An important finding of this study also was that in patients not receiving oxygen, dexamethasone had no effect, and if anything, it was associated with a trend towards increased mortality. That's why dexamethasone should be used, but not be used too early. It has to be used once patients require oxygen. Dexamethasone was used at these doses in the recovery trial. Other groups have used other corticosteroids like hydrocortisone, methylprednisolone, and there was a large meta-analysis from the WHO showing essentially that different corticosteroids have similar effects. So if you don't have dexamethasone, it is okay to treat patients with hydrocortisone. However, I want to point out that, for example, for the data in hydrocortisone, the confidence intervals of 28-day mortality actually included 1. So even for those corticosteroids, the effects are going to be small. In the subgroup analysis, differences between corticosteroids and non-corticosteroids remain significant by gender, by presence of mechanical ventilation, oxygen, age, days, and symptoms. However, there were no significant differences in patients if patients were receiving bioactive drugs. And importantly, there were no serious adverse events in any of the groups. Okay, so now we have an antiviral and one immune modulator. What's new? What are we? So we need new immune modulators and we need new antivirals. So which are the new immune modulators? So the first immune modulator that has reached the clinic is Tocilizumab. Tocilizumab was used already during the first wave, and this has been a long story, a long and winding road, with trials showing different effects of Tocilizumab and a lot of discussion. I think that at the end of the day, the study that settled down the question is the recovery study. This is, as you know, is a very large study, the same study that led us to approve dexamethasone. And here in the recovery study, patients receiving Tocilizumab did much better, had better survival than patients not receiving Tocilizumab. And this was despite the fact that more than 80% of patients in both arms were receiving corticosteroids. And also the second characteristic is that Tocilizumab was given only to patients with evidence of inflammation, meaning PCR above 75. So if you do that, if you do it in that way, so Tocilizumab has positive effects. So in the same recovery trial, they evaluated, so did a meta-analysis of the mortality in the different randomized clinical trials. You can see how confidence intervals were very wide in the previous randomized trials, showing that they were either too small or maybe being done in populations that were very heterogeneous. Overall, these meta-analysis concludes that that Tocilizumab is actually being effective. There is a second study called REMAP-CAP, which was done mainly in patients entering the ICU. ICU means semi-critical care and critical care. And again, in these patients, the use of Tocilizumab shortened the amount of organ support required, and was also associated with reduced mortality if Tocilizumab was used during the first 24 hours after getting into one of these critical care units. Then, so Tocilizumab has been incorporated, and now we have another immune modulator, which is Baricitinib. So Baricitinib is a very interesting drug. It acts inhibiting, is a JAK1/2 inhibitor. And baricitinib was identified through artificial intelligence analysis. And there was a publication in March in 2020 in Lancet suggesting that baricitinib could actually have both anti-inflammatory effects, but also some antiviral effects, because it would be inhibiting endocytosis mediated by clathrin. Studies in animal models have confirmed that baricitinib had very potent anti-inflammatory effects, with reductions in inflammatory cytokines and chemokines, neutrophil and macrophage recruitment, reductions in netosis activity, and reductions in activated T cells. So this was, of course, very, very promising. The next, then the Act 1, if you remember, Act 1 was testing remdesivir versus placebo. The next comparison became remdesivir plus baricitinib relative to remdesivir plus placebo. And Act 2 then showed that baricitinib plus remdesivir did better than remdesivir alone. And differences were seen overall, but overall the effect was small, only 1 day gain in clinical recovery. But if one focuses in the baseline ordinal score of 6, which is patients in the semi-critical care units, patients requiring high-flow nasal cannula or non-invasive mechanical ventilation, there in those patients, you could gain up to 8 days in clinical recovery. Again, Act 2 was not designed to evaluate mortality, but it certainly implied an advantage to the previous drugs. It has been recently published, at least in medRxiv, results from the COV-BARRIER study. The COV-BARRIER study, standard of care plus baricitinib was compared to standard of care plus placebo, and there you can see also reductions in all-cause mortality by day 28. So baricitinib is a new kid on the block, is a new drug that could be used. But then the question is, how do we position baricitinib? In a scenario where we have remdesivir plus dexamethasone, then we have tocilizumab for patients who are not doing well, or patients with very severe hypoxemia. Where do we use baricitinib? So the first that we had to do was to compare baricitinib with dexamethasone. And to make a long story short, the Act 4 trial did such comparison, and what Act 4 found was that remdesivir plus baricitinib is comparable to remdesivir plus dexamethasone. So, which is good and bad for the drug. It's good because it shows that you can combining remdesivir plus baricitinib is something that you can do, that is much better than remdesivir alone. However, the bad part is that baricitinib is much more expensive than dexamethasone. Dexamethasone is readily available everywhere. And if baricitinib is not better than dexamethasone, then probably what we would do is to start with dexamethasone and then see where we can position baricitinib. So one option we could be using baricitinib in a few patients that do not tolerate dexamethasone. For example, recently we used it in a patient with psychosis where dexamethasone was not indicated. And also another possibility that is being discussed is to use it in patients who develop failure to remdesivir plus dexamethasone treatment. Okay, and many other immune modulatory drugs are coming. So what about the new antivirals? Yes, we have remdesivir. Remdesivir has a moderate effect in only some patients. Yes, vaccines are being very effective, but it is very likely that we will see an increase in new cases with the new Indian variant, but also still we have a number of patients with severe immune suppression. For example, patients receiving rituximab or patients with organ transplantation who either do not respond well to vaccines and are not able to develop a good protection. So there will be also perhaps the elderly in the long term. So there are pockets of patients that will require new antivirals. So which are these antivirals? The most promising one until now was, until very recently, was Molnupiravir. Molnupiravir is a citidine-derived nucleoside in ferrets. Can you hear me well?
No, Roger.
Sí, em sentiu bé?
Ara sí.
Okay. Apologies.
But now we can hear you.
Showing that ferrets, sorry, can you hear me now? Apologies for that. Ara em sentiu bé?
Now, yes, sí, ara sí.
Okay, apologies again. So, both in ferrets, Molnupiravir was able to reduce the viral load very quickly in these ferrets, and also to prevent transmission of SARS-CoV-2 to other ferrets that were co-housed. However, so Merck started 2 clinical trials, the MOVE-IN clinical trial in hospitalized patients, and also the MOVE-OUT clinical trial in outpatients. The MOVE-IN clinical trial in hospitalized patients was stopped because Merck made the decision not to continue this drug, because essentially it did not show any effect on hospitalized patients. The publication is being written and will be available very, very soon. And the MOVE-OUT data seems to be more promising, and we will have to see what happens. There is a new antiviral called Plitidepsin, which is actually quite romantic. It is a synthetic cyclic decipeptide isolated from a marine tunicate. It's called Aplydium albicans. Aplydium albicans is shown here. It can be found in the waters of Ibiza. Now it is being synthesized. In the lab. And actually, Plitidepsin targets the eukaryotic elongation factor, EF1A. And therefore, such interaction, this is a factor that cells require in order to grow. So such interaction may lead to hampered efficiency of de novo viral capsid synthesis, viral replication, and decreased viral load. And since this drug is targeting a host factor, one of the advantages is that if this drug would work, it would be effective against many different variants, because it would be targeting a host factor. Plitidepsin is in preclinical development. It achieves, we know that it achieves in vivo supra pharmacological concentrations in the lung, so it gets good concentrations in the lung. And preclinical phase 2 studies and PK/PD studies have shown that it can be used in different doses, and possibly between 2 milligram per dose, 2.5 milligram per dose are the doses that will be being tested in phase 3 clinical trials that are coming. So we need to wait until we need to test this drug in phase 3 clinical trials. Data in phase 2 clinical trials has been promising, but it's not enough to say whether this drug will work or not. Then another approach has been convalescent plasma, and there have been a lot of publications. Essentially, convalescent plasma, to make a long story short again, convalescent plasma might have some effect if it's given early with high titers and in patients without their own antibodies in outpatients, okay? However, in inpatients, convalescent plasma does not add any benefit as a treatment given for everyone. There are, however, situations, for example, in severely immunodepressed patients, where you could be using convalescent plasma. And I'll give you one example. We have a patient that developed 4 consecutive COVIDs, and she is severely immunosuppressed. She's taking rituximab, and she also has a chronic lymphocytic leukemia. So she's not able to develop her own antibodies, and we treated. She got well with remdesivir in the 4 consecutive episodes, and in the last 2 episodes we gave her again convalescent plasma, we get for the first time after the third episode, and we were planning to give her convalescent plasma again by day 21, and on day 21, when she came to the visit, she had clinical symptoms again. So now what we're doing is we're giving her convalescent plasma every 2 weeks. And since we're doing that, she hasn't had a new episode. So convalescent plasma and passive immunotherapy might have a role. It does not have a role for all patients taken as a whole, but it might have a role in very selected patients, particularly the immunosuppressed. Okay, so what is the next? And what we are now testing is the monoclonal antibodies. There have been a lot of studies. There are a lot of studies coming in testing monoclonal antibodies, both in outpatients, but also in inpatients. And so this is the area that will grow more in the coming weeks, actually. So how are we working? So this is the area where we are doing most of our research nowadays. So we are involved in the International Network for Strategic Initiatives in Global HIV Clinical Trials, the INSIDE network. This is a collaboration that evolved from a collaboration for multinational HIV trials funded by the Division of AIDS, NIAID, and here you can see that this network has a global presence, 37 countries on 6 continents. This is very important because we can continue doing the clinical trials regardless of where COVID is. So if we have low COVID numbers here, we know nowadays, for example, at least in Southern America, we have plenty of COVID-19, so we can move very fast identifying new trials. So in previous trials in HIV, this network has been very successful, and now we have a number of COVID-19 clinical trials going on, testing hyperimmune immunoglobulins, but also a number of monoclonals. The way it works is we work in a multi-arm, multi-stage platform master protocol for clinical trials called Active3 or TICO, and essentially, what we want to do is to test as many antivirals as we can. So we have a number of agents that have looked promising based on the phase 2 or sometimes even preclinical data. And then we start testing for these antivirals. And once we have a certain amount of patients, there is a DSMB review that looks for both safety and whether the antiviral is able to achieve the primary endpoint. If there is any safety signal, the antiviral is stopped and we don't test it anymore. And also if there is futility, signs of futility, we don't test it anymore. And this allows us to test many different trials. Active is actually one of the 4 main branches of the NIH. Active 1 is the branch looking at immune modulators. Active 2 is neutralizing monoclonals in outpatients. Active 3 is in inpatients, and Active 4 is the anticoagulant therapy. So we are the group working on the Active 3. Active 3 is funded through funding comes from the U.S. government, and it incorporates big cohorts from the INSIDE cohort, but also the CTSN and the PETAL cohort. So it's a global partnering that allows us to produce a number of publications. So far, we've been able to produce up to 3 New England Journal papers looking at remdesivir, Baricitinib, and then the Lilly compound. And now we have data on the papers waiting also on the hyperimmune immunoglobulins and 2 other monoclonals. The story so far with monoclonal antibodies is that monoclonal antibodies, here you can see a comparison of the Lilly compound in outpatients and in inpatients. The Lilly compound in outpatients had some effects, so it reduced viral load and reduced the hospitalization rates. However, when this Lilly compound was used in inpatients, it did not have any effect. We should be expecting similar data from other monoclonals, particularly the GSK-Vir monoclonal is looking very promising, and also the Brie monoclonal, and now we are evaluating the AstraZeneca monoclonal. One caveat of these findings in hospitalized patients is that whereas monoclonals are not useful, as you can see here, for all patients taken as a whole, what we are seeing now is that there is a subgroup of patients, which is those patients who did not develop their own antibodies, yet where actually giving them a monoclonal antibody is better than placebo. So we should be expecting a subgroup of patients, maybe through a little bit more personalized medicine, in which these monoclonals could help. So what's next? So Gilead is testing a version of remdesivir that can be inhaled or taken orally. And then we are just about to test a different type of antivirals, which are the DARPins. DARPins are shown here. These are the small molecules, like 4 small molecules linked with a linker. Each of these small molecules is 1/10 of a monoclonal antibody. It's much smaller, and they bind to the RBD domain. And at least in vitro, they have a very strong efficacy, and also they are easily produced and could be cheaply produced. So this is something that we are very eager to evaluate. And also we have new protease inhibitors being also on the road that will be evaluated. For example, there is a protease inhibitor from Pfizer that could be having additional effects to remdesivir. Finally, one area that is completely blind is the clinical trials in the ICU patients. So we are starting the Tocilizumab clinical trial. The Tocilizumab is also a platform, similar platform to TICO, but in ICU patients. It's led by Sam Brown from Utah, and also with the INSIGHT cohort. There are different groups in the US, Denmark, Singapore, and Spain that are being involved. You can see a number of different participating sites. And again, the Tocilizumab works like TICO. Like there is an agent selection committee, which is independent, that assesses agents for inclusion into Tocilizumab. Then all the preclinical data is considered. And once a drug is chosen, then it is included in the protocol. And the primary objective of this protocol is to determine whether these investigational agents are safe and superior to control in ICU patients. So we are focusing in patients receiving high-flow nasal cannula, non-invasive ventilation, invasive mechanical ventilation, or ECMO. The first iteration will compare aviptadil, which is vasoactive intestinal peptide, versus remdesivir, versus aviptadil and remdesivir versus placebo. And this study has started to enroll in the US and will be starting to enroll within 1 month in Catalonia and in Spain. So in conclusion, we have different phases. COVID-19 is a multi-stage disease. We require different treatments for different stages. So remdesivir would be located in this intermediate phase, the pulmonary phase. Monoclonals and plasma are better positioned in outpatients or in very selected patients, particularly immune-suppressed patients. Dexamethasone is increasingly important as the patient deteriorates, and particularly to treat a host inflammatory response phase. And finally, we have the IL-6 and JAK inhibitors that also come to become part of antiviral treatment of COVID-19. Let me finish by thanking all my team and also a team of all researchers, but particularly my team in the hospital, which did all this research while, like you guys, seeing tons and tons of patients, and this is, we don't have enough words to thank what they did. So thank you very much.
Thank you, Roger, for your interesting presentation. And now, please, if you have any questions.
Roger, this is Elizabeth. I'm a biologist. I'm not taking care of patients or knowing or being close to bed. But I would like to know your opinion on what is the future of the treatment of COVID patients, because I'm not sure if what we are or what you are doing now, it cannot be improved, or it can be only a little bit improved, or there is a gap towards the real future and what we can really do in the future to treat COVID or equivalent virus infections.
Okay, so I'm an optimistic person. So one day I asked myself, why am I so optimistic? And because the world doesn't look good. But then I realized that maybe it's because I'm coming from the HIV world. And we did have similar situations in HIV in the past. So now we have in terms of antivirals. So the first question is that mortality in hospital mortality continues to be high, even though the population mortality will be reduced overall, and so COVID will be killing less people. Once someone is admitted at the hospital, for example, if you have a young person admitted at the hospital, this is because you have a bias, because all the people who did recover, you're not seeing them, and the ones you see are the ones that are actually very sick. And once they get in the hospital, at least in Catalonia, in hospitalized patients with these last 2 waves, we had at least 10% mortality. So we need better drugs. The drugs we have are only partially effective, and for sure in antivirals they can be improved, and they can be improved very much. There is a lot of so we will control the pandemic through vaccines. Nevertheless, there will still be groups of people who will not develop good responses to vaccines. This could be the elderly or very elderly, but also the immunosuppressed, in which we will require drugs to treat these patients in the outpatient setting. Monoclonals are okay for an American environment, but I'm not sure if they are so okay for a primary care environment in Catalonia, for example, or in Spain. What we will require is oral drugs or inhaled drugs that are much more effective, and also possibly combinations of drugs. It would be possible to combine, I would say, remdesivir, for example, with oral remdesivir with an oral protease inhibitor from Pfizer, for example, and in vitro, at least, we see that they have synergy and that they do much better inhibition of what's going on the body. And then we need better immune modulatory agents, and the last area where we need a lot of improvement is also in anticoagulants, because most of our patients actually have microthrombosis and there is and a lot of inflammation. So I do think that the drugs will get better. There was a lot of improvement already, although and they can get better with better penetration, with better mechanisms of action, and much more targeted.
May I have a question? I'm Joan.
Hello, Joan.
Yes, thanks for this very interesting and excellent talk, Roger. And I wanted to ask you about if there is any difference in the efficacy of the treatment that you have mentioned, according to some phenotypical characteristics of the patient, because as you know, people with obesity or with type 2 diabetes have a more serious evolution, mainly when they are at the intensive care unit. If these clinical assays have been has been analyzed according to these phenotypic characteristics. Thanks.
Yes, so all assays are looking for these characteristics, and they slice the populations down, and they don't see any difference. So we tried. There was a discussion in the CISCAT guidelines to see whether remdesivir, for example, could be preferentially used in a certain type of patients, and we really looked into it, and there's no data. We don't see any difference. So the effectiveness is the same in older than younger patients. What I think is going to happen is that we will have some like a baseline treatment for everyone, and then we will add specific drugs to some patients, and particularly in the immunosuppressed. So this idea that what we are seeing now is that although we published in the New England Journal saying that the Lilly monoclonal antibody is not effective in hospitalized patients, when we look back into the data set and we separate patients that were able to develop their own immune response. So if they have antibodies, we do antibody testing. If they have antibodies, their own antibodies, this monoclonal is not adding anything. It's because they already have their own antibodies, and an additional monoclonal is not changing anything. However, if they don't have their own antibodies developed, haven't developed their own antibodies, then the Lilly monoclonal is better than placebo. This is being looked at with different monoclonals, and possibly we will require specific clinical trials, because what this is telling us is that, at least for the monoclonals, could have a role in immunosuppressed patients, or in patients, so immunosuppressed patients, or patients seen very early. And that would be relatively easy to do. It would be because you would see a patient, you would give a patient, I would say, the standard treatment, remdesivir plus dexamethasone, and then you would test for antibodies. And if the patient does not have their own antibodies, then adding a monoclonal could be much better. It could contribute to cure the patients earlier and reduce mortality. The way I see COVID-19 is like if it was a transatlantic boat. So it comes to us, it arrives to us, and then we stop. Okay, we put treatments to stop the evolution, but there's an inertia, and patients get well. Say, require time after we put them on treatment in order to get well. So the harder we hit at the beginning, the better. The shorter the time to recovery. Yeah.
Okay. Thank you, Roger.
You're welcome.
Okay, so remember to the participants that if you wish to ask him any more question, you can do it on the chat and we can ask him later on. So Roger, thank you very much for your presentation.
Thank you. Thanks a lot.
And now let's move to next speaker, Cinta de Diego. She's member of the research group of Wellbeing and Disease Prevention Transversal Program led by Dr. Martin Lujan. The presentation is called COVID-19 related and all-cause deaths among people over 50 years during the first epidemic wave in Tarragona, March-June 2020.
Vale, doncs moltes gràcies. Faré la presentació en anglès. Les diapositives també estan en anglès. D'acord? So I will present this study. It's entitled COVID-19 related and all-cause deaths among people over 50 years during the first epidemic wave in Tarragona between March and June 2020. The study was conducted in the Unitat de Suport a la Recerca d'Atenció Primària de l'ICS del Camp de Tarragona. Següent. Direct and indirect COVID-related mortality is nowadays still uncertain. This study investigated all-cause and COVID-related deaths among middle-aged and older adults during the first wave of the pandemic period, assessing mortality risk by pre-existing socio-demographic and medical underlying conditions. Podem passar a la següent i la següent també. Aquí. This is a population-based cohort study with 79,083 individuals 50 years or older. They were followed from the 1st of March until the 30th of June 2020 in Tarragona. in the region of Tarragona. We included here Tarragonès, Alt Camp, and Conca de Barberà counties. All of them were affiliated to 12 primary care centers of the Institut Català de la Salut and represented 75% of the overall inhabitants in this age strata according to the census data. As baseline co-variables at the beginning of the study, we have age, sex, place of residence. It means if they live at the community or a nursing home, pre-existing comorbidities, vaccinations, and chronic medications. The endpoints were death from COVID, confirmed laboratory by PCR or serology, and death from any cause occurred among cohort members between March and June 2020. So the mortality rates for COVID-related and all-cause deaths were calculated per 100,000 person weeks. We calculated also absolute numbers and frequencies for the distinct population subgroups. And mortality risks were assessed by Cox regression. Cox regression analyses were used to calculate unadjusted, age and sex adjusted, and multivariable adjusted hazard ratios, and to estimate also the association between baseline conditions and the time to the first outcome. So, okay, let's see the results here. We can see that during the study period, there were 576 all-cause deaths. 124 occurred among the COVID-confirmed cases and were considered as COVID-related deaths. After checking the clinical records, we observed that 90% died by COVID and 10% due to other causes, but with COVID. So, considering COVID-related status at the end of the study period, we classified the population in 4 subgroups, as you can see here. All-cause mortality rate was 42.5 deaths per 100,000 person weeks. You can see that in the healthy people, the mortality rate was 22.8, but in those with negative PCR, the mortality rate was 10 times higher than in the healthy ones. It arrives until 236.4. The ones with clinical symptoms but without a PCR done, the mortality rate was 493.7. And finally, in the last one, we see the ones with positive PCR, the mortality rate was 4,009. So here we can see the mortality rate according to age, and as expected, the highest rate is in the group of the oldest, that were 80 or older. So here we can see the mortality rate by sex. We observed that all-cause mortality was higher in men than women. And next, please. The mortality rates depending in the place of residence. Here we can see the mortality rate from any cause is very high in those that live at nursing homes, but also the mortality rate related to COVID was really high among those living at nursing homes, arriving to 286.5 deaths. So continuing with results, here you can see the mortality rates according to the previous comorbidities. As you can see, neurological, renal diseases, and also cancer had the highest rates. So here in this table, we can see the adjusted risk of death from all-cause mortality in the total study cohort, unadjusted, age and sex, and multivariable. Increasing age, male sex, and nursing home were associated with a significant increased risk of mortality. Also neurological disease, cancer, cardiac, and liver diseases were associated with higher risk of mortality after the multivariable analysis. This is the adjusted risk of death from all cause. And now we will see in the next slide the adjusted risk of COVID mortality. If we consider COVID-related mortality risk, in the crude analysis, we observe that cancer, neurological, renal, respiratory, and cardiac diseases, and also diabetes and hypertension, appeared associated with an increased risk of deaths, but none of them appeared significantly associated with an increased risk after the multivariable adjustment. Again, increasing age, to be a man, and living in nursing home were the stronger predictors for COVID-19 related mortality. And in conclusions, we can say that COVID confirmed deaths accounted for more than 1/5 of the total mortality observed in the cohort. Among deaths with positive PCR, 90% died by COVID and almost 10% died with COVID. Increasing age, to be a man, and to live in nursing homes were associated with increased COVID mortality and also all-cause death, but no comorbidity was independently associated with significant increased risk after the multivariable adjustments. Apart from COVID-confirmed deaths, theoretically, COVID-excluded patients with negative PCR suffered 10 times greater all-cause mortality than the healthy ones. This fact suggests the possibility of false negative PCR results and could explain part of the excess all-cause mortality observed across the pandemic, especially at the beginning of the pandemic. Okay, thank you very much. Si teniu alguna pregunta ho podem fer en català o en anglès. Yeah. Is there any question?
Cinta,
Sí.
This is Elizabeth Vilella. Well, do you have any explanation why you did not found associations, for instance, with obesity?
For instance, sorry?
With obesity.
Yeah. Maybe in the total population we have more or less 50% of overweight, but maybe there are few or poor registration at the clinical histories.
Okay.
There is an under registration, I think. This is maybe one of the causes.
Is there any other question? Okay, thank you very much. So,
and now, going to the last part of this seminar, I'm going to present Lyell Reverter, which is going to present us the results of their study. Laia belongs to the group of infection and immunity at the Hospital Joan 23. And Laia, the floor is yours, and you can present your data.
Thank you, Cinta. Thank you, Elizabeth. Sorry. Let's share the presentation. Can you see the presentation?
Yes, perfectly.
Okay, thank you. So, well, COVID-omics is the project that has started from the beginning of the pandemic and has been funded by BioCat from Health Department of la Generalitat de Catalonia. And during these pandemics, and thanks to the established internal and external collaborations of this project, we managed to create a well-defined and dynamic patient cohort of a total of 761 patients. Once they have been admitted to the hospital, we classified them according to the clinical criteria and the manifestations into 4 categories, from the least to the most severe, into asymptomatic, mild, moderate, and severe. In the asymptomatic group, as obvious, we classified the patients that didn't require hospitalization and present no symptoms, but also other patients that go to the hospital for other reasons and became positive once they were in. Then the mild group includes patients that did not require hospitalization but present mild symptoms such as fever, cephalea, ageusia, anosmia, etc. In the moderate group, we include hospitalized patients with moderate symptoms such as pneumonia, respiratory distress, among others. And in the last group, the severe one, we have the hospitalized patients that require intensive cares and presented severe pneumonia, respiratory failure, hemodynamic instability, but also patients with that were unsuitable for aggressive measures and finally died. In this project, we perform a longitudinal study starting at the acute phase of the infection, what we call baseline, and then we follow up patients along all the healing phase and taking the samples at 1 month, 6 and 12 months. Specifically, we collect plasma samples in order to identify the predictive biomarkers of disease severity by the multiomics analysis. Then we also aim at the identification of inflammatory markers by this quantification by multiplex ELISA of succinic acid and related molecules. And also, we want to evaluate the association risk between comorbidities and COVID-19. Until now, this project resulted in 2 publications. The first one, published in the Journal of Personalized Medicine, determined that obesity and metabolic syndrome worsen the COVID-19 prognosis. In the second study, the epigenomics study was performed in collaboration with Dr. Esteller from Josep Carreras Leukemia Research Institute, in which they collect genomic DNA of a total of 400 patients below 60 years old without comorbidities and with different severities. And they were able to identify several epigenomic factors associated with disease severity and also with respiratory failure. If we move on to the main objective of this project, which is the determination of biomarkers of severity and also prognosis biomarkers, here we show that this multiomics analysis was performed only in one part of our big cohort of patients. Specifically, we used this total of 279 patients, and the asymptomatic group was included in the mild group because we didn't observe differences, significant differences regarding the metabolics profile, the multi-omics profiles. So we included them all together here. And what is interesting here to mention is that as previously known by other studies of COVID-19, all the patients that were that belongs to the severe group were preferably men, older, died in higher proportion and present more morbidities in comparison with mild and moderate groups, which seems to point out male sex, age, and comorbidities as risk factors associated to disease severity. With the aim of finding more biomarkers of disease severity, we performed the multi-omics analysis in this cohort of patients at 2 time points, at baseline and after 1 month of the infection, at the recovery phase. And we analyzed the proteomics, the metabolomics, and the lipidomics analysis. If we look at the left plot, we can see how the 3 omics allow us to differentiate the 3 groups of severities. In blue, you have the mild group, in orange, the moderate group, and in gray, the severe group. And also, you can see the positive correlations among between the 3 omics. On the right-hand side, in this surplus plot, we can see the correlations that we obtain with the significant proteins, metabolites, and lipids among this patient cohort. If we look into more detail what says each proteomics and at each time point, we can see on the left how at baseline the pathways and number of proteins involved in the acute phase decrease as the infection progresses. So this seems to indicate that the patients are recovering well and that the inflammatory cascade characteristics of the beginning of the inflammation is slowing down. If we move to metabolomics analysis, we can see these 3 distinct patterns among the different groups of severities, although some patients share a common pattern regardless the severity. And interestingly, after 1 month of the infection, if we look down, we can see that the mild and moderate group share a more common pattern, while the severe group has a more differentiated profile. This could be attributed to the most critical patients within this severe group. And similar to what we observe with metabolomics, with lipidomics, we can also observe 3 different profiles of lipids, sharing again a common pattern at baseline. And as the infection progresses, we can see that the severe group has a more significant distinct profile, showing that maybe these patients are not, the severe one, are not recovering as well as the others, so they are still fighting against the infection. And at this point, and still having a lot of data to analyze all together, we ask ourselves, what else can we do? And we decided to follow up these patients also after 6 months and after 1 year of the infection in order to evaluate the long-term effects of people suffering COVID-19 that are well described from the literature and are affecting a vast part of the population. And also we would like to determine the multi-omic profile in plasma, but also in subcellular populations. And we believe having all this picture all together, the entire picture of the mechanism of action of this disease, we will be able to determine which are the best biomarkers of disease severity to define the immunological and metabolomic COVID-19 signature in order to do a better patient stratification and thus to provide a more personalized therapy. And this is all. Thank you very much.
Any questions for Laia? Laia, I have one question. I don't know if I lost it or you did not mention it, but I guess that the treatment would interfere with this data. So do you correct or do you use the treatment as a covariable in this analysis, or do you correct or stratify patients according to treatment?
You mean for the classification of the patients or for the multiomics analysis?
For the multiomics analysis.
Well, we are taking them into account, of course, everything. We are making a big database, so we are including everything: the treatment they receive, the previous treatment they were receiving before having COVID, the comorbidities, everything, if they need oxygen therapies or not, and we are of course taking them into account. But here I only present the simplest results just to simplify in 10 minutes. But of course it's really important to have them into account.
Okay, thank you. More questions for Laia, for any of the speakers?
There is one question in the chat for Roger. It says, could you mention some of the interleukin-6 inhibitors that are used or going to be used as anti-inflammatory pharmacs for COVID-19 patients? We cannot hear you.
Now.
Yes.
Yes. So there are at least 3 anti-IL-6 drugs that have been tested. Tocilizumab is the only one that has strong results and is therefore included in the guidelines. Then we have Tocilizumab is given intravenously. Then we have data from Sarilumab. Sarilumab studies have not been very conclusive so far. Also, it has been used much less than Tocilizumab. However, there is data from the REMAP-CAP suggesting that Sarilumab could have similar efficacy to Tocilizumab, but the numbers of Sarilumab in REMAP-CAP were much smaller, and therefore the data is not conclusive. The advantage of Sarilumab is that it has a subcutaneous formulation, and therefore it could be given in patients who do not tolerate intravenous formulation. Finally, we have Siltuximab. Siltuximab has been tested in a clinical trial led by the Clinic Hospital by Felipe Garcia relative to comparing Siltuximab with dexamethasone. The clinical trial has been finished, but we don't have the results yet, so we will know if Siltuximab could also be used. Other sites have used anti-IL-1 inhibitors, anakinra, for example. Anakinra had very good data from observational cohorts and small studies, but the largest, so the Corimmuno trial, has not been able to show a conclusive effect of anakinra. So as of today, we are left with Tocilizumab, and all the other ones are being evaluated. There will be more anti-inflammatory drugs coming in. For example, we have the anti-GCSF inhibitors that have been shown some effects, particularly in the elder, in more than 70-year-old patients. But those studies are still in preprint, and COVID has taught us to wait until we see the final results, because sometimes there's a joke on the internet, right, about the press release, which is a very strong guy, then the preprint is a weaker guy, and then the final paper shows much weaker results. So I would recommend caution until papers are published.
Maya, you're still sharing the screen.
I'm sorry. No?
Yes. Some more
Apologies, sorry.
questions? If not, it's time to thank again the speakers. Thank you very much. You have shared with us your results obtained during this intensive year, as Roger said, no? Intensive in terms of individual health and individual well-being, but also challenging in science. So thank you also for all the participants to be here, and we hope to see all of you tomorrow, because we have the second part, and is a complement to what has been presented today. So bye-bye to everyone, and see you tomorrow. Thank you. Bye.
Thank you very much. Thank you. Bye-bye.
Bye. Thank you.